Dear nephrology colleagues, my name is Peter Stenvikel. I'm working at the Karolinska Institute in Stockholm, Sweden, and together with my co-chairman, Professor Christoph Wanner at the University Hospital Würzburg in Germany, I welcome you to Live 2021 Nephrology Campus. In this series of 18 webinars, we present to you current trends in nephrology. Before we start the next webinar, there are some housekeeping rules. You as an attendee, you should be automatically muted and invisible. But please feel free to ask questions via the question field in GoToWebinar at any time. So now it's time for webinar number 12. And it's an honor for me to introduce Dr. Lili Chan, who works at the Mount Sinai Hospital in New York. And Dr. Chan, she will present about machine learning in nephrology. Dr. Chan.
Hi everyone, this is Lili Chan. I'm from Mount Sinai in New York, and thank you to the committee for inviting me to give this presentation. We're going to be talking about machine learning in nephrology today. My only disclosure is that I am a consultant for Vifor Pharma on a topic unrelated to what I'm talking about today. So what we're going to go through is, first we'll do a brief review of what machine learning is. Then we'll talk about how machine learning has been used in nephrology so far. And we're going to end with how we developed and validated a machine learning model for progression of diabetic kidney disease using biomarker and EHR data. So we'll start with what exactly is machine learning. So machine learning is a subset of artificial intelligence. Artificial intelligence are simply techniques that enable a computer to mimic human behavior. Machine learning uses statistical models to enable a machine to improve with experience. So you expose the machine learning model to large amounts of data, and then it identifies patterns that we can use for categorization and prediction. Deep learning is a subset of machine learning, which uses multiple layers of artificial neural networks to learn, which mimics the human brain. And so while we hear about machine learning a lot in the news and in research, it's really pretty integrated into our lives at this point. So this is just a screenshot of Google Maps, which looks at my drive if I went from work to the Empire State Building, and it generates these estimates of how long it would take me depending on the route. And these are derived using machine learning. And if you've also done any online shopping at this point, you can get these suggestions based off of what you've previously purchased, and also based off of what other shoppers like you have also bought. And this is also generated using machine learning. Another example is using Google Translate, which identifies your original language and then translate it into Spanish. So these are all common examples of machine learning that are frequently used in our lives. So machine learning can be classified into two different groups, supervised learning and unsupervised learning. Where supervised learning, data is labeled and you tell the machine what you want to look for. While in unsupervised learning, data has no labels and the machine will look for whatever pattern it can find. And so supervised learning is often used for classification and regression. And these are different types of algorithms that are used for each case. So when we're talking about classification, an example would be if you had pictures of cats and dogs that are labeled cats and dogs, you then train the algorithm on these pictures, and now you have a group of photos that are not labeled of cats and dogs, and you ask the machine algorithm to then classify for you. While in regression, this is most commonly used more for a continuous variable. So for example, you have a list of students and you have their age and gender and height. And you train the model on this list. Now you have another list of students and you only have their age and height, and you ask the algorithm to then predict the height of these patients. And for unsupervised learning, the most commonly used is for clustering. And again, these are the different algorithms that can be frequently used for clustering purposes. It's often an example of clustering is marketing. So whenever you look at your social media accounts or you're looking, surfing the internet, and you get these advertisements, these ads are generated from machine learning based off of what you've previously searched for, or whether or not you fit into certain demographic groups and they think that these ads would be useful for you. So how has machine learning been used in nephrology so far? So this is one common use case where a machine learning algorithm is trained to identify the different portions of kidney from kidney pathology slides. So this group, published in 2019 in JASN, developed a convolutional neural network, which is a deep learning algorithm to identify the different segments of a kidney biopsy sample from transplant cases and also from nephrectomy cases. And what they did is they compared it to pathology segmentation, and they used a dice coefficient. The dice coefficient looks at the overlap of what the machine learning approach identified as versus what the pathology annotated as. And this number can range from 0, no overlap, to 1, full overlap. So a dice coefficient of 0.88 is pretty high. They also used this algorithm to identify the different components of the BAM scoring system, and they found that this highly machine learning derived BAM score highly correlated with the pathology derived one. And this is a study that we did back in 2019, and we used natural language processing, which is computer software to help us read through free text and identify 7 different symptoms from 1,000 dialysis patients. And this was compared to the ICD codes, and this was using read on EHR data. And what we did find is that the NLP approach, natural language processing approach, had higher sensitivity and negative predictive value than ICD codes with similar specificity. Another use case is for the prediction of acute kidney injury. And this was a paper published in Nature, and they developed a recurrent neural network, again, another deep learning approach, to do continuous prediction of acute kidney injury. So for example, this is one particular patient who was hospitalized from 0 to 8 days that developed acute kidney injury at hospital day 5, and that's panel A, based off of creatinine. And on panel B, the green line is the actual prediction generated by the model over the different time periods of hospitalization. The red line here is the threshold at which the model would then consider the prediction to be positive, meaning that the patient would be at risk of having AKI within the next 48 hours. And so this crossed the threshold at hospital day 3, which was approximately 48 hours prior to the actual event. On top of prediction of AKI, it also can generate predictions for the different laboratory variables. So that's on panel C, this is the creatinine, BUN, and potassium levels, where the green line is the predicted by the model, and the blue lines are the maximum values of the actual labs. And they found that this model had high area under the receiver curve of 92.1% and a pretty decent area under the precision recall curve of 29.7%. And so now I'm going to move on to our project, which was risk prediction of progression of diabetic kidney disease. So us as nephrologists know that patients with diabetic kidney disease can progress in many different ways. Some will never progress, some will rapidly progress, and there's everyone in between, which we have a difficult time telling whether or not they will progress or not. And currently, we often refer to this KDIGO categories, which is based off of eGFR and albuminuria. And we know that patients who are in this green zone here are probably safe, while those in the red here are probably going to progress. But the problem is all these people in between, how do we appropriately counsel them if we have a difficult time risk stratifying them? And one of the most commonly used equations is the kidney failure risk equation, which was developed by Tangri in 2011. It was developed in 3,000 patients and validated in approximately nearly 5,000 patients. And the final model consisted of 8 different features, which were patient demographics along with laboratory variables. And what is important to note about this is that about 40% of patients had diabetes, and the baseline eGFR in this cohort was 36 and 31%. So these patients actually had pretty advanced kidney disease already. And you would ideally have a risk prediction model which identified patients early on in their kidney disease course, which allows for the most interventions to have an impact in the overall prognosis. And this is a slide that looks at the different biomarkers apologies. This is a slide that shows a figure that we are currently working on a systematic review of different biomarkers that are currently getting published in different cohorts. And what the kidney failure risk equation did not include are any biomarkers into that, even though growing data does suggest that plasma biomarkers are likely associated with CKD incidence and also progression in several studies. And what I also wanted to highlight is that KIM1, TNFR1, and TNFR2 are three of the most often studied biomarkers with the highest strength for prognosis. And so working with Renalytics, we developed Kidney Intellects, which is a risk prediction tool that includes biomarker information and EHR data. So our cohort included 1,146 patients enrolled in the BioMe Biobank at Mount Sinai and also at the UPenn Biobank. Patients were included if they were G3A or G3B with any level of albuminuria, while they were G1, G2 with moderate albuminuria. They had to, based on EGFR, was considered to be the EGFR between 1 year before or up to 3 months after biobank enrollment. In order to ensure adequate follow-up, they had to at least have 21 months of data and also 3 EGFR values after baseline. In patients who did not have a urine albumin creatinine ratio measured, this was imputed to 10 milligrams per gram. The cohort was randomly split into 60% derivation and 40% validation, and the derivation cohort was further split into training and test sets. The primary outcome of interest for this model was progressive decline in kidney function, and this was defined as a rapid kidney function decline defined as an EGFR slope of greater than or equal to 5 mLs per minute per year, a sustained decrease in EGFR of more than 40% confirmed at least 3 months apart, or kidney failure, an EGFR of less than 15, initiation of long-term dialysis, or kidney transplantation. And these are all of the features that were potentially eligible for inclusion. We had demographics, laboratory values, including 3 plasma biomarkers and the ratios of the biomarkers to each other, ICD-9 codes, medications, and vital signs. And just to note that because we were using data from 2 different institutions, there did involve a lot of data harmonization in order for all of the features to match. So for example, looking at laboratory values, all lab values were linked to LOIN codes and only were included in the study if they were present in more than 70% of subjects. The medications were also linked to RX norm, and we only included the top 20 ICD codes and the top 30 medications. And the algorithm that we decided to use was the random forest model. And a random forest is actually a decision tree-based algorithm. So this is just a simple decision tree of whether or not I should go for a run outside. And this is the first node. Did I go for a run yesterday? And each of these yes or no's are the branches of the tree. And after each branch, you then go on to a decision of no, do not go for a run, or no, it leads to a different node. Is it raining? Yes or no? And then again, it'll generate a prediction or an outcome. And random forest is called a forest because it's not simply one tree. It's an example of an ensemble learning approach, meaning that there's n numbers of trees. Each tree is then going to generate a prediction, and all of these predictions are then going to be averaged, and that is the final random forest prediction. This is the baseline characteristics of the study population overall and also by derivation and validation. And because they were randomly split, you can see that the patient characteristics were pretty similar. What I did want to highlight is that the follow-up time in months was 52 months overall. Based on EGFR was 54, and about 38% of patients were missing urine albumin to creatinine ratio. And this is really reflective of the US institutions overall. And this is a table that shows the area under the receiver curve for kidney intellects compared to the KDIGO classification and also the clinical model. The overall composite outcome occurred in 21% of the population, while the hard outcome, meaning ESRD, was in 5%. And as you can see, the AUC was higher for the kidney intellects for both the train validation in the composite outcome and also the in the train and validation for the hard outcome. And this is a shot plot, which indicates the top predictive features within the model. So let's just look at the systolic blood pressure here. Each of these points is a data point from the cohort. And the purple over here indicates that a high systolic blood pressure on the right side of the middle indicates that a high systolic blood pressure by the purple dot is going to push the model to predict a positive outcome, while a yellow dot here onto the left of the middle means that a low systolic blood pressure is going to push the model to predict not having the outcome. And what I also wanted to highlight is of the top 12 features pictured here, sorry, there's a bit of a delay with my clicking, that of the 12 features predicted here, 5 of those features were actually biomarkers and the ratios of the biomarkers. And when we then organize the patients into their kidney intellect's predicted risk, an orange dot indicating that the patients did have the outcomes, and the blue dot here indicating the patient did not have outcomes, you can see that patients who had a higher predicted risk had a higher risk overall of having the actual outcome, while those in the lower risk group were less likely to have the outcome. And this was the same across the derivation and also the validation cohort. We then grouped patients into low risk groups, intermediate, and high risk based off of kidney intellect score. And we found that the low risk group overall had an average risk of 10% of the event, 22% in the intermediate risk, and also 61% of the outcome in the high risk group. And when we look at just the simply sustained 40% decline in eGFR or kidney failure within the validation group, again keeping the same 3 risk groups, low risk, intermediate, and high risk, it's clear that the high risk group had much lower survival. Hazard ratio for high versus intermediate and low of 9.1, while high versus low was 14.7. And now if we look at the different test parameters of the low risk group, I want you to really focus on the negative predictive value here for the low risk group. Because in the low risk group, you want to make sure that if your test is negative, you're identifying these patients as negative, not having the outcome, they truly will not have an outcome. And this was much higher for the kidney intellects compared to the optimized clinical model. While for the high-risk group, you want to look at the positive predictive value, meaning that if your test is going to identify this person as having the outcome, they truly will have the outcome. And again, kidney intellect had a higher positive predictive value than the optimized clinical model, 63%, 61%, and 37%. And then if we focus on simply those patients who developed end-stage kidney disease within 5 years, the KDIGO classification identified only 37% of those patients as being high risk, while kidney intellect identified 73% of these patients as being high risk. And when we look at how the reclassification occurs, this is the KDIGO classifications in the validation cohort, which identify 52% of patients as low risk, 32% is intermediate risk, and 16% as high risk. And looking at the KDIGO yellow, which are the low risk group, kidney intellects group them as 54% as low, with an event rate of 9%, while 9% were high, with an event rate of 56%. KDIGO orange, the intermediate group, for kidney intellects 42% was low risk, with an event rate of 10%. 22% identifies high risk with an event rate of 58%. And if we now look at KDIGO red, which is the high risk group, kidney intellects identified 15% as low risk and 0 of them had the event, while 43% were considered high risk with an event rate of 75%. And now, how do we move from going to the bench, going from research to actual clinical implementation? And before we get to that, I did want to highlight several things that we have to take into consideration. You have to make sure that any models are tested and developed in a diverse population. I'm sure you've seen in the news about what's been happening with facial recognition software, where it was only developed and tested in one type of population, and it didn't apply to other populations. We also want to make sure that these models have undergone external validation. So the model might work great at one institution, but this might be related to some underlying pattern and something unique to that institution, and it may not be generalizable to other hospitals and institutions. We also want to make sure that these models add to the workflow and they don't actually inhibit it or get in the way of physicians taking care of patients. We want to make sure these models make sense, that they're interpretable, and that we're not just giving labels to patients, giving them a high-risk label without giving the providers an idea of what they can actually do. And lastly, we want to make sure that the outcomes are something that are intervenable on. We're not finding patients, categorizing patients so late in their disease course that we can't modify their disease. And what I was surprised to find is that there's actually several examples of machine learning already in healthcare. So I was on call one weekend and I was looking at the CT head of one of my patients, and I found that we are using artificial intelligence within our institutions to do some brain imaging reading. And there's also companies like Path AI, which are developing machine learning algorithms to read pathology slides for. And this is Project Inner Eye, which is another machine learning approach developed by Microsoft, which assists in doing imaging reading and speeds up radiation planning for patients. And so Kidney Intellects is currently getting tested at Mount Sinai. And what it is in patients who have diabetes and chronic kidney disease, they get a blood draw done, and EHR elements are extracted from EPIC, which is the EHR used here, and these are put into the machine learning algorithm. And this is an example of what the test report would look like. So there is a score that patients are given, and they're classified as high, intermediate, or low risk. And then there's also examples of clinical pathways, so interventions that are potentially be helpful for the care of these patients. And this is the proposed workflow that Kidney Intellects has. So here they have care navigators who will identify the patients who meet the inclusion criteria. They can order the Kidney Intellects test directly in the EMR. It's integrated into Epic and penned it for the provider. Patients are given information about the test, providers are given information about the test, and this is the actual report that would be generated. Once patients are classified as either low, medium, or high risk, there's different care pathways that can be followed. There's also different information and education training for the different providers. And lastly, we have to track the progress of these patients. Are they progressing? Are there changes to therapy or management? Are patients getting referred to nephrology earlier? Are patients and also physicians satisfied with the scores and the reports that are generated? And like I said, this is actually undergoing clinical utility studies at Mount Sinai right now. We have 2 care navigators who are identifying the patients. Once they are scored, they have different pathways that they can follow, and there's monitoring of the patients at 6 months and 12 months. And this is getting led by Dr. Joji Tokita here at Mount Sinai. And so there's a lot of factors that contribute to the care of patients with diabetic kidney disease, and Kidney Intellects proposes one model to address some of these barriers. We have care navigators to identify appropriate patients who would benefit from this study. We then have a simple tool that classifies patients as low, medium, or high risk. Once these patients are categorized, there's also different recommendations for care paths, including education, diet, potential medications. And there's different tracking of patients. So our care navigators are following the patients, seeing when patients do have progression of their kidney disease, referring them to nephrologists. And the hopes of doing all of this is to alter the course of patients' kidney function, prevent patients from crashing into into hemodialysis, and really stabilizing their overall care. And with that, I will end my talk, and I'll take any questions.
Thank you, Dr. Chan, for this amazing lecture about the kidney intellect. I would now like to urge all those out there listen to this talk to ask questions via the question field in the Go To webinar. So I can start while we wait for the first question. I find your data really interesting and would like to know if you had studied the impact of sex on these factors. Do males and females behave differently with regard to progression, and how you can predict that?
I don't know if we specifically, I don't recall specifically looking at gender, but we did not suspect that there would be necessarily any differences. But we did look at different subgroups of different amounts of follow-up and different, whether or not we imputed or didn't impute albuminuria, and we didn't find that the model behaved any differently across any of these subcategories.
Okay, so here is the first question from the audience. How do you think the healthcare system influences effectiveness of machine learning in clinical practice? For the kidney intellect to be effective, patients must have access to biomarker testing, which may not be true depending on, let's see, HCS,
The healthcare systems.
healthcare system that the patients are in.
I think that's very true. You know, we are lucky that it is currently approved to be used in New York, and it's gone through vigorous testing already. So that's are doing this clinical utility study to enable it to be used more broadly. We are also aware that they're also doing additional testing in different cohorts. So I think that's an access issue, which is also true of any test. You know, if we don't get BMPs in our patients, we won't know what their kidney function is. So I think that's a very true issue. And I think this also depends on, you know, in the US, our healthcare systems are very fragmented, while in other countries like Canada, they actually have a much more unified healthcare system. So there definitely is going to be variability of uptake and also availability.
Can I have the next question, please? Have you considered histopathology on outcomes? May not apply to diabetes kidney disease alone.
I think we've considered it, and that's one of the reasons that we decided to use a machine learning approach and also the random forest model, because we hope to potentially expand and add additional either biomarkers or pathology slides in the future. And the random forest model will allow, you know, easily for us to be able to add additional features. The problem, I think, with the histopathology is that many of our patients don't end up getting kidney biopsies done, especially patients who have diabetes, because we just suspect that, well, this patient has diabetes, it's uncontrolled, and we simply add that label on. So unless we have universal use of everybody getting a kidney biopsy, I think it'd be difficult to necessarily add that to these models.
Can I have the next question, please? Machine learning uses ground truths as final outcome. However, once chosen, these become actually black boxes of which no one longer knows what they actually mean. In the Tomasev example of acute kidney injury was defined only on serum creatinine.
Right. So in that Tomasev case, they did use serum creatinine to do the KDIGO classification for AKI. I think that's actually a pretty acceptable ground truth. Granted, you know, the question of whether or not urine output should be included is a separate question that often at times research, they just don't have the availability of the urine output. Machine learning, I think, does tend to have one of the cons is the black box, which you cannot necessarily know which features were important. So there are some new techniques. I think the Shapley plot, which I showed, is one of the newer techniques to look at how the different features impact the overall model prediction. And you can at least identify whether or not the top features contributing to your models make sense. And that's why one of the things I said with for consideration is that these models are interpretable. We're not just giving them, people a number like, oh, this person's high risk, but physicians don't actually even know where this model is pulling that information from. So I think that's a very important thing. The black box also tends to be more into the deep learning approaches, so the neural networks are even harder to interpret, at least for random forest approach, and some other machine learning approaches. Also, you can at least look at the different features and see how they play into your prediction model.
Next question, please. So on a more general line, what other applications do you think machine learning can have in nephrology in the future?
I think that is such a broad question. I think the pathology is probably most at the forefront right now because a lot of institutions don't have a dedicated renal pathologist. And also for the research side, it could also help speed up the pathology reading. Obviously, that'll still need to be validated with the pathologist in the end. But that's probably the most, I think, feel the lowest hanging fruit right now. My personal interest is actually looking at using natural language processing and identifying social determinants of health. And that's clearly been highlighted that these matter, especially during the COVID pandemic. So I think we can now apply it to more of a patient outcome approach and a more population health approach to identify these potentially modifiable risk factors rather than, just identifying a disease itself.
Okay, so let's see if there is one more question here for you. Yes, there is. In your experience, what are some of the best countermeasures against overfitting?
Well, that's a difficult one. I think one there depends on the algorithm that you're using. So certain algorithms are going to be better for overfitting versus other models. There's also, you want to make sure that you don't end up putting too many different features on, because then you're going to end up putting in a feature that the model is going to hang up on, because we've run into situations where we were training a model, I think it was on echo data, and we ended up finding that, the best predictor was which technician ended up doing your echo. So I think those are some things that we just want to take into consideration.
Thank you. And next question, please. What are your thoughts on the use of machine learning spanning across multiple specialities, or using machine learning on a combination of clinical and non-clinical data?
This is one of those times where I wish I could actually speak to the person, because I'm not quite sure what they mean by spanning multiple specialties. I can presume maybe like a model used for like a more general task versus nephrology, which I think eventually we'll get there, but I think cardiology and nephrology tend to have been doing a little bit more research, so I'm not sure where that's going to go. But a lot of the pathology and also the imaging that will necessarily span across different specialties, and in combination of clinical and non-clinical data, I think ultimately we want to bring that non-clinical data to the clinical, included into our clinical models, and that's what we're doing with using the biomarker data, because a lot of it is not currently used in clinical practice. It's only being used in research. So yes, we should be doing this.
Yeah, so maybe if the person that asked this question want to discuss this more in detail, he or she can contact you via your email or Twitter account.
Absolutely.
So do we have any more questions for Lili? Yes, we have. Out of the 4 considerations that you've listed, which one is the most difficult to overcome and why?
I'm going to have to say most of those you can't overcome, because those are design elements that you yourself select, except for the external validation portion. It's very difficult in order to combine data across institutions. A lot of hospitals have certain protections for their data. So the new approach right now is a lot of people are looking into federated learning, which kind of you're sharing the weights of the features instead of the actual features. So you have a model that's trained, you share the weights with another institution, it's retrained using those weights and modified, and then it's kind of regrouped together. And that's kind of the newest approach to kind of overcoming that. But I haven't seen it being used too much yet, so I can't comment on any results yet.
So I guess this was the last question, and I would like to ask, thank you, Lili, for answering these questions so nicely and also for presenting very interesting data. And I'd like to thank you out there in the audience for your participation. I'd like to remind you about the next webinar, number 13, which will be on April 22nd. And then we will be visited by Professor Wim van Biesen and Dr. Ariane Salosik that will talk about approaches to tailored dialysis modality. And finally, in September 15 to 18, we will arrange the live 2021 Nephrology Congress. And I would like to ask all of you to save the date, for there will be a number of very interesting presentations during this meeting. Thank you for participating.